So good afternoon, everyone. We are now on track 3. So we are going to talk on very apt and important points that are given in track 3, which talks about zero harm. And I welcome Captain Dr. Hunmana to be the co-chair for this session. I welcome Madam Varsha Srivastava, who is the NABH Nursing Excellence Standards. She is the Deputy Director at NABH. We have with us the young leaders who are going to make a difference, and ANI is all about giving this platform, such a big national platform, to these young leaders who are going to talk to us from bedside what is going to be the experience towards zero harm as a caregiver. So we have with us Ms. Alisha and Ms. Ruchita, who will be talking to us for this. Welcome both of you. And we also have with us Ms. Gayatri Digambar Rahane, who is the Assistant Manager, Endocrine and Diabetes Care Specialist. Welcome to you, Madam. So talking about zero harm in healthcare refers to a patient safety philosophy and organizational commitment aimed in preventing all avoidable harms that are done in healthcare to the patients, by healthcare workers and visitors during delivery of care. It means creating systems, processes, and a culture where preventable incidences such as medication error, hospital-acquired infections, patient fall, pressure injuries, wrong side surgeries, all or avoidable deaths are minimized with the ultimate goal of eliminating them entirely from the system. So the core principles of zero harm, it's better that we understand to the fullest. The core principles of zero harm talks about prevention of preventable harm, like for an example, preventing patient falls, avoiding medication administration errors, reducing catheter-associated infections, preventing pressure ulcers and DVT complications. The second point, which is very important about the core principles, is safety culture. Zero harm promotes a culture where the staff reports error without any fear of a punitive action. Team communication is being encouraged. Learning from incidences becomes a routine in the organization, and leadership prioritizes patient safety at the full. And then system-based approach. It talks about, just I'm giving an example, what do you mean by system-based approach? It is standard operating procedures, safety checklist, double-check medication protocols, and infection control bundles. The fourth core principle, which is mainly harping on continuous quality improvement, and which talks about monitor safety indicators, audit clinical practices, analyze incidences, near misses, implement corrective actions so that we can achieve the target in achieving zero harm. So here we have our first I would request Dr. Hunmana to talk about the first speaker. Dr. Hunmana, please.
Hello. Already Madhukari explained about the topic. I'm directly going to the speaker. Alisa Mustaq Khan, staff nurse, Janjir Hospital, Pune. It is just for you.
Thank you, ma'am. Thank you for giving me an opportunity to sit here and speak about my thoughts. Thank you. A very good afternoon to one and all present here. Thank you, ANEICON, for giving me an opportunity to speak on this prestigious platform. Thank you, Neeta ma'am, who is my CNS. Thank you, Jahangir Hospital, who has supported me for coming here and expressing my thoughts. I know I'm very young, but I think if young professionals can bring up their thoughts, as Sir said, that Gen Zs must speak up in order to make a change. So I stand here to make the change and to introduce what I faced when I was a staff nurse and what I believe should be changed and should be practiced. Zero harm is patient safety approach aimed at eliminate all preventable harms, ensuring no patient is injured as a result of healthcare. It is a goal, it is a standards that we should maintain. Zero harm should not be just written in paper or written in the policies that we are having or according to NABH standard, but it should be beyond all those things. I believe not only NABH standards, but it should come from the heart and from the actions of a staff nurse or a professional who is standing in front of a patient and delivering a care. So in order for us to prevent harm, there are a lot of preventable measures that we can take. Those are safe handovers and clear communication. When we take handovers from our senior staff or our colleagues, it should be so clear that we deliver quality care to our patients and not just merely actions that will make the patient feel, oh, she's just coming and doing her work. But in order for us to do so, we should be clearly communicating the handovers. Next is adherence to the infection control protocols. I vividly remember that when I was a staff nurse, I'm still a staff nurse, but I want to grow ahead also. But I vividly remember when I was a staff nurse working in daycare, there used to be some infection control nurses coming around and watching me and then just noting down something and going ahead. They didn't used to tell us that what is wrong with me, what have I done wrong, or what I have made wrong, so that I can prevent that harm or prevent that action of mine in further practice. Next is patient identification and medication safety. Most of the time what we do is we just, without the file, without the identification of patient, go to the patient's bedside and whatever there are medications, we just give it to the patient. We just don't really make note of that we should really carry patient's medication chart or file along with us so that we deliver right patient medication and right identification of medication as well. So these are some aspects which I faced when I was a young nurse. Nobody taught me in a clear manner that it should be done so that you deliver care that is causing no harm to patient. Next is respect, dignity and informed consents. Obviously, if as sir said, in order for us to be respected, we should also give respect to others. So when I respect a patient, definitely the patient is going to respect me and talk to me nicely. And then we are making respecting the patient's autonomy, its dignity, and we are making the informed consent so that we deliver care that does not cause again harm. So these things prevent the harm, and this is how we can prevent the harms in our daily practices. Going ahead, listening to patients and their families, partners in care. So most of the times what happens is, I've also worked in ICU, and then I used to see that we independently take decisions for an ICU patient who is lying on the bed. Sometimes the relatives also are least bothered to just see at their patient and decide something. Most of the time patient may get a pressure injury because a nimbus bed was not applied. Most of the time they might have problems with the billings. So including family and the relatives in care is equally important, where we somehow fail to do so. That's what I believe, and we are practicing that, but we deny to accept that thing as well. Let us remember that safe care is not optional. It's our duty. Zero harm begins with me, begins with you, and with every step that we take in healthcare. Thank you so much, and I believe that this is how we can prevent the harm. Thank you so much.
Alicia, thank you so much. You finished before time. Okay. So we have now with us Ruchita Datta, who is a staff nurse of Fortis Hospital, Anandapur, Kolkata. Ruchita, the stage is for you. Yeah.
Only for 3 minutes.
7 minutes.
Good afternoon, everyone. Respected dignitaries, senior nursing leaders, and my fellow healthcare professionals. I am Ms. Ruchita Datta, staff nurse from Critical Care, Fortis Hospital, Anandapur, Calcutta. Today, I will be presenting on the topic, Zero Harm, that starts at the bedside. Zero harm is not merely a hospital policy. It is a commitment, a culture of vigilance, accountability, teamwork, and compassionate nursing care. I will start discussing simple yet powerful nurse-led practices that significantly reduce preventable harm. Starting with prevention of patient fall, in critical care we see patients often weak, sedated, confused or attached with multiple devices, so which make them highly vulnerable. Simple nursing interventions make a larger impact and major difference, ensuring call bells are within reach, proper use of side rails, safe transportation while sending the patient before transportations or any procedures, safety signage, close monitoring of high fall risk patients. We also need documentations like modified Morse for adults and Humpty Dumpty for pediatrics. Next. Next is pressure injury and skin damage. Hospital-acquired pressure injuries and skin damage directly affect patient comfort, recovery, and dignity. Now, how many of us do really go at the bedside and check patient's skin before taking handovers? We really miss it, like due to heavy workload, we sometimes miss it. Isn't it a part of handover too? It really takes 5 minutes to do skin assessment, right? Regular skin assessment, repositioning, moisture control, back care, and providing air mattresses, which if required, and documentation, which is most important, as in Braden scale, are essential bedside practices. Moving on to the next is perioperative safety. Totally depends on communication, teamwork, and strict adherence to protocols. The WHO surgical safety checklist includes 3 important stages: sign in before induction, time out before incision, and sign out before closure. 3 steps help prevent wrong site surgery, retain instruments, and medication errors. Next comes blood transfusion safety. Now, blood transfusion can save lives, but even a small identification error can become fatal. So we always see when, suppose a patient whose hemoglobin is 5.9 and the patient comes to the ward and doctor says that, Ruchita, you have to transfuse the blood immediately. How many of us do cross-check, and cross-check? We tell the doctor, please put the BT note, and then we call a senior, and the senior cross-checks, and we think that, yeah, okay, fine, the doctor has given the BT note, he must have checked, the senior also must have checked. But how many times do we check? Do we cross-check before transfusing the blood? And if something happens, who is responsible? You are the allocation staff, so it is your responsibility to take care of the patient every minute, every shift, and every time. Next comes EWS. So now we all know that early warning score, or EWS, helps to identify patient deterioration before a critical event occurs. For early recognition, we just have to remember 4 things, which is A, V, P, and U: alert, verbal, pain, and unresponsiveness. So if we check EWS in a very cool parameter, we just need to check the EWS and AVPU and vitals all together, which also creates patients identify the pains and the heart rates and all, everything early, so we can detect and monitor early as soon as possible. So overall, in a nutshell, we see that zero harm in healthcare is not a dream or a slogan or a target on paper. It is a promise we owe to every patient with continuous improvement, strong culture, and bond between healthcare staffs. Measuring what matters, empower our juniors, and do safe practice, because we all know that prevention is better than cure. But how in healthcare, excellence is not just counted by how many we treat, but by how safely we heal. So that's all for today. Thank you.
Thank you very much, Rusika. So beautifully you explained the perioperative, and all critical moments. Okay, it is really praiseworthy to hear you. Okay, so now I'm going to the next topic, that is one patient, one plan, nurses' role in coordinating multidisciplinary care. Yes, I witnessed when the surgeon advised in critical care experts, they used to cancel the order. Okay, so like we are progressing, we are learning, we are evolving, but sometimes we forget to collaborate. Yes, there is difference from the doctors to doctors, practitioner to practitioner, but who can make the bridge? That is only nurses. Many times nurses are said they are the backbone. I deny it. Nurses are not backbone, they are central nervous system. If you are the central nervous system, then you have to ignite your knowledge, you have to be updated, you have to upskill yourself with the technology and evidence-based practice, of course. At last, not the least, your EQ, emotional balance is most important. Understand yourself, understand your capability, understand your weaknesses, and accept others. So here, we have the expert to hear that, Gayatri Digambar Rahana, Assistant Manager, Endocrine and Diabetes Care Specialist. Please, over to you.
Good afternoon, everyone. Thank you, ma'am, to give me opportunity to speak. Thanks to Elizabeth David, ma'am, to nominate me, and thanks to Sir H.N. Reliance Hospital. So today, I am going to talk about one patient, one plan, a practical framework that positions nurses as anchor of coordinating multidisciplinary care. The presentation focuses on how nurse leader can reduce the fragmentation, improve the communication, and strengthen the patient advocacy, and create measurable improvements in outcome through structured coordination. So this is a fragmentation problem. Healthcare today is highly specialized, but unfortunately, specialization often creates a loss. Patient moves between physician, therapist, pharmacist, social worker, and nursing team. And when communication breaks down, nurses are usually the first to notice the consequences. Fragmentation lead to the delayed discharge, medication error, repeated interventions or investigation, poor patient experience, and staff burnout. The key issue is not lack of expertise, it is a lack of coordination. So these are some data, like 1 in 4 patient experience a care coordination failure during hospitalization. 40% of medical errors are caused by communication breakdowns and between provider. There is lot of financial loss just because of the coordination disturbance. So these numbers are from AHRQ, that is Agency of Healthcare Research and Quality Care, the coordinations measures. The nurse is an anchor. The nurse is only clinician present across all shift, transition, all handoff. Because of continuous presence, nurses naturally becomes an information hub, care translator, safety watchdogs, and team coordinator. Nurse connect the clinical information, patient concern, family expectation, and team action into the concurrent story. This is why coordinated care cannot success unless nurses are empowered to lead it. What is the one plan? So the one plan is not simply the documentation in EHR. It is living, shared framework created collaboratively by healthcare team and the patient. Every discipline works toward the same goal, like what is the goal for today, what is the discharge goal, when is the patient plan for discharge, shared responsibility, and patient's priority. The nurse is not writing everyone else's plan, but nurse is designing the structure and keep the whole team aligned. Patient complexity stratification. That is, in our hospital, we call it as patient acuity score. Not every patient requires a same level of coordination. High-risk patients need an intensive multidisciplinary management, while routine admission may need a simpler coordination. This stratification helps us prioritizing the nursing coordination and resource effectively. The important principle here is the patients still have a named nurse responsible for maintaining the records and maintaining the shared plan. The DNA coordination model. So the DNA model stands for technology, nursing, and advocacy. Technology supports the communication and early detection. Nursing integration, all information in actionable care. Advocacy ensure the patient voice remain central. These pillars are work together to create safe, coordinated, and patient-centered care. So moving to the S bar in practice. S bar, like I think we all practice the S bar. So is the one of the most powerful tool for structure communication. That is situation, background, assessment, and recommendation. It helps nurse communication clearly and confident during the escalation and handoff situation. The important point is that S-bar is not only in reporting the data, it is about the experiencing a clinical judgment and requesting for the clear action. Structure communication reduces the ambiguity and improves the patient safety. Interdisciplinary round. In many of the hospital, rounds are reactive and fragmented. In nurse-led rounds, the nurse begins with the patient goal, overnight concern, and current priorities. The information rounds from passive information sharing into active coordination because the nurse is the only one who understands the patient thoroughly. The nurse ensures that the actions are assigned, documented, and followed through. There are barriers in coordination. So there are predictable barriers to coordination care. Slows in the department, there are EHR gaps, like there is fragmentation in the notes. Physician notes, nurses notes, dietitian notes, all are documented separately. Staffing pressure, the hierarchical culture. Nurse solve this barrier through the structure hurdles. So in all the department, there is something called as starting of the shift, we plan a huddle. Patient snapshot, complexity-based coordination, and escalation culture. Leadership support is critical to make the solution sustainable. So the patient advocacy in action. Advocacy is not an optional nursing role. It is patient safety responsibility. So nurse advocate for informed consent, cultural mediation, escalation concern, discharge planning, and addresses social determinants of health. Now going towards the digital anchor. Now as we heard, we have to become a tech savvy. There are so many applications coming in place. So technology should be strengthened nursing coordination, not to replace the nursing judgment. AI system, telehealth, and unified EHR can improve the early detection and continuity of care. But technology cannot replace our empathy, bedside assessment, advocacy, or therapeutic relationship. The nurse remains coordinator and clinical decision maker, measuring the outcome that matter. So this is how we need to coordinate the measurable results.
Hello, you have 1 minute more.
Sure. Length of stay graph. The graph highlighted the operational impact on lead nurse coordination. So strengthening a nurse leader. We cannot expect nurse to coordinate care effectively in the system and does not support the nurse themselves. Burnout directly affects the communications. One patient, one plan in practice. In the case study demonstrate the difference between fragmented care and coordinated care. Without coordination, communication, it is not possible. Core competencies, the implemented one plan successfully. Communication, system thinking, digital skills, interpersonal relationships, and advocacy. These are very important core competence. Implementation roadmap. Implementation should be done in the phases. There is key performance indicator. Nurse leader must know the data conservation. The psychological safety. The goal is not to comfort. The goal is a safe communication. So the leadership action plan. The slide translate concept into the immediate action. Formally identify the coordination lead, audit rounds, and began structured debrief. One patient, one plan, one anchor. Great coordination often becomes invisible because everything works simply. Behind that invisible coordination, it is usually we, the nurses, ensuring communication, alignment, advocacy, and continuity. Thank you very much.
Thank you, Gayatri. One thing that we have seen now from all the three young leaders that they have spoken, one shift that has happened in healthcare that has been brought by nurses across in healthcare. What is that? From reactive to become proactive. And who brought this change? We nurses. So a big round of applause for all nurses present here. That's the wonders that we have brought in healthcare. And now we have a director, deputy director NABH, Ma'am Varsha, who is going to give us a clue about NABH Nursing Excellence Standards. Second edition talks about zero harm. Madam, you have 10 minutes, please. Thank you.
So a very good afternoon to all the respected dignitaries here, the nursing professionals and the nursing leaders present here. So first of all, I would sincerely like to thank you all for allowing me to be a part of this ceremony and this session and giving me an opportunity to interact with such esteemed gathering. So it is indeed a privilege to address such a dedicated and compassionate fraternity that forms the backbone and are the anchors of the healthcare industry. So nurses, what I believe is, do not only provide care and comfort to the patient, but also uphold the values of commitment, excellence, and the empathy in the healthcare delivery. So I will not take much time, and I'll just take you through a brief presentation on the NABH second edition Nursing Excellence Standards. So the experts have already told you about the no harm and no defect. So I will take you through the journey, like how NABH developed its standards and what are the initiatives NABH has taken in this second edition which were not there in the previous edition. And I feel actually proud to say that most of the stakeholders, most of the expert committee members who have actually contributed and have developed these second edition standards are present here. So thank you so much all of you. And thank you so much all of you for giving your feedbacks also on the development of these standards. So a small introduction to Quality Council of India, NABH. So Quality Council of India is an independent autonomous organization under Ministry of Commerce, and NABH is a constituent board of the Quality Council of India. There are 4 other boards under QCI and other projects also which run. So we very proudly say that our chairman is being appointed by the Honorable Prime Minister of India, and we are working towards our goal of our Honorable Prime Minister, Viksit Bharat. So NABH started its journey way back in 2005, and the first accreditation standards were developed in 2006. So currently the second edition of Nursing Excellence Standards are based on the 6th edition standards also. So we have taken inputs from the 6th edition standards, and then these standards have been drafted. So this is the vision and mission of NABH to be the apex national healthcare organization. And these are our values on which we all rely on, like credibility, responsiveness, transparency, and innovation. So the core activities of NABH involves accreditation, certification, empanelment programs which we have, and the other government projects what we have, what QCI has been working upon. So all these details you will be able to find on our NABH website also, what are the different accreditation and certification programs. Now, NABH standards are freely available on our NABH website, so you can go and download the PDF version of the standards. And just to say that the Nursing Excellence Second Edition standards along with the guidebook have been uploaded on the website. So they are freely available, and we are not selling any hard copy of these standards. So you can download them. You just need to register yourself on the website, and they are freely downloadable. One thing what I would like to iterate here is the Gunavatta Chakra. So the Quality Council of India has started this initiative with all the boards of QCI, and it is Gunavatta Chakra, which involves different elements and themes. What I would focus upon is on the Gunavatta Pathshala initiative, what we have taken, and what I was talking to the esteemed nurses over here, that there are various trainings which have been involved under Gunavatta Pathshala initiative. So there are trainings for the nursing fraternity also on the NABH nursing excellence standards, and also the role of the nurses in the hospitals. So I would definitely like you all to go through the website and check out these trainings, and also to give your feedback on these trainings, that whether we need to incorporate more or we need to improve them more. So I would like to have your inputs on those, because you are the ones who are actually working on these things. Now, the development of the nursing second edition standards. The first edition was launched in 2014. It was long way back. So, depending upon the feedbacks what we have received from our different stakeholders, we have revised these standards. And these standards are dedicated basically to strengthen the nursing quality in the healthcare organizations. Then focused on professional excellence, patient safety, and continuous quality improvement, designed to align nursing practices with evolving healthcare quality expectations. So if the hospitals are following the accreditation standards, so nursing excellence is also a part of that. Then there are 7 comprehensive chapters under nursing excellence program, and these chapters are divided into 60 standards. Then these 60 standards are individually divided into 302 objective elements, and to introduce the quality indicators which all the nurses and the nursing departments are already capturing in the hospitals. We have incorporated these 22 indicators also in our current standards. So the key revisions, what I will tell you is there are few names of the chapters which have been revised. Nursing quality improvement is now as continuous nursing quality improvement. Then infection control practices is now infection prevention and control. Nursing care of patient is redefined as a professional nursing practice. Empowerment and governance has an added element now, which is the leadership, to strengthen the nursing leadership and participation, what we have been hearing since morning today. Then there are references attached at the end, so easily they can be referred to. Now, what are the key elements which have been focused upon this time on the second edition are the patient safety and risk reduction strategies, the structured induction, orientation and training programs, the leadership development and empowering of the nursing professionals. And there is continuous quality improvement initiative which have been added in the chapters this time. So the expected impact on healthcare organizations is these standards aim to support the continuous professional development of the nurses, the skill enhancement, ethical and patient-centered care, then alignment of the healthcare organizations with global quality benchmarks. So this was a brief presentation. You will find all the details on our NABH website, and the entire guidebook is available. So I would request you all to please refer to the guidebook and let us know if in case any improvement is required, because we also want to work towards continuous quality improvement. So you can please give your feedback on that. We will also be ruling out a questionnaire maybe later. I'll check with the organizers and we can have your inputs to that questionnaire also. So I am here till, me and my colleague Ms. Ilsa Ansari, we are here till afternoon, till after the lunch today. So if in case you have any query or anything, you can please come back to us and we will be happy to assist you. So I would like to end my presentation with just one saying: empowered nursing professionals are central to achieving excellence in patient care. Thank you so much.
Thank you, Varsha. Thank you very much. Such a big topic. You have capsulized it and very well presented. And I just would like to say there are 2 principles for the healthcare, particularly for nursing care. Number 1, the priority is patient safety. Number 2 rule is we have to work for the patient safety. So in this 3 presentation, I have seen like we cannot afford to do harm if we cannot do good. Okay, that is number 1. Number 2, of course, one patient, one plan. And the NABS excellence will definitely lead us to the better height. I being from the government institute, also from AIMS, I am also looking for nursing excellence, and I look forward for your support and help. And this is actually the standard criteria. Whatever we are doing, you might be doing the best, you might be excelling. But when we are going through a standard and protocol, it's become easy for us to prove. Okay, that's all. Thank you from my side. Thank you all the speakers, and I'm handing over to our chair, Madhukari.
I thank from bottom of my heart and on behalf of Annie to all the speakers. We are very happy to see Annie has come up with all the young leaders to talk and present their thought processes with us. How is the Josh before lunch? Very low. How is the Josh? Okay. So I think we have been having a fruitful discussions, and thanks to all the members, those who have been present here in this session track 3. And once again, I thank Annie for giving us opportunity. Thank you.
Thank you. Thank you, ma'am. Requesting the chair, co-chair, and all the speakers to kindly move to the photo corner. Thank you.